This is my journey. Inspired one story at a time, a library of leaders was created. It began as a journey to learn. As time went on, it began to grow. All it needed was a platform, and this podcast was created to listen, to inspire, to share. I am a storyteller, and this is my journey. Welcome to another episode of Profiles in Leadership. I'm your host, Steve Anderson, and this episode is brought to you by Hychara Health. That's S-I-L-N-A. The premium front-end RCM company that leverages technology with a team of onshore insurance experts to handle benefit checks, eligibility checks, and prior authorizations. Finally, a vendor that you can trust, like a full-time employee that scales with your business. Just mention the Profiles in Leadership podcast to receive a free trial. Our guest today is Chris Hoekstra. Chris received his PhD in biomedical informatics from Oregon Health and Science University School of Medicine. His Master's of Science and Doctorate of Physical Therapy degrees come from Pacific University, and his undergraduate degree was in biology from Willamette University. He is board certified in orthopedics and a fellow of the American Academy of Orthopedic Manual Therapy. Additionally, he completed a postdoctoral fellowship in clinical informatics through the National Library of Medicine. Chris has worked as a physical therapist, a clinic director, a health IT consultant, and more recently, Chief Clinical Transformation Officer for Therapeutic Associates. In that role, he has overseen the company's strategy related to the use of organizational data in business and clinical decision-making. With this new program called Hychara Health, Chris oversees product development, program and project management, and sales and marketing strategy. He's been on this show before. He's one of the few people that is a repeat, but if you want to go back, we're not going to spend a whole lot of time on his professional career because that's covered mostly in the first episode. That is episode 83, and it was released January 11th, 2021, and neither of us can believe it's been that long since we did this before. So, Chris, welcome to the program. It's great to have you back.
Thanks, Steve. Great to be back.
So let's talk a little bit about, well, actually before, there's one thing I didn't read in the bio that I'm always interested in, so I just want to hear it. So you're a physical therapist, you're a numbers geek, you love the informatics, all that kind of stuff, but you also volunteer in police work. So tell us a little bit about what you do there and why you do it.
Yeah, I mean, the why I do it's the big reason. It's all about service. I mean, at the end of the day, when I do all the informatics stuff or the work I do for Therapeutic Associates or Hychara or consulting, at the end of the day, it's trying to help people out. And so I got into law enforcement. I had a heart for service and that sort of thing. Ended up treating a lot of police officers early in my career and got invited to become a reserve deputy to help decrease injuries in police officers, and just fell in love with the service opportunity. So I did that for 9 years. When I moved out here to Tennessee, that credential doesn't transfer across states. So I found a different way to serve. I'm now an operations officer for a military police battalion for the Tennessee State Guard. So similar sort of role, but now we work a lot in disaster relief. So Helene, the hurricane that came through, we did disaster relief for that. But it's a military police operation. So how do we help keep those things secure? But at the end of the day, I love numbers, but I love serving people more. And it also scratches an itch. I sit at a desk a lot. So to run around in the forest or run around chasing bad guys, it's also scratches a different itch for me.
And so that's a complete voluntary position, I presume.
Yeah.
Yeah, that's impressive. Well, thanks for doing that kind of work. I'm sure we could use smart people like you doing more of that. Not that others in that world aren't smart, but I mean, I just think it's that volunteer part of it is just so awesome. So let's jump into what you're currently really working on and what you're excited about. Hychara, did I say that right?
Yep. Hychara.
Hychara Health. So tell us first what the name means and why you picked that name, and then kind of give us just a summary of what that program is and what you're trying to do.
Yeah. So Hychara Health is a kind of an advisory services and a managed service organization to help healthcare organizations take off administrative burden. So Hychara, the reason we picked that name, it's kind of from two Greek words. So Hygeia is Greek for medicine, health, and then Kara is Greek for joy. And it seems weird to put those two together, but we could all admit that right now in healthcare, it's hard to be joy filled in the business of healthcare. And so we've tried at Therapeutic Associates over the last several years to make that a core focus of what we're doing. And then we've asked ourselves, how do you do that? And part of that is removing the burdens that take people away from what they love doing, which is caring for patients, serving your community. And so Hychara is really there to help deburden those administrative functions or those number crunching things that geeks like me like to do. We know healthcare businesses need, but they waste a lot of time doing them and takes them away from other stuff that brings them joy.
So now, those who don't know, you and I know each other pretty well. I was the CEO of Therapeutic Associates. Gosh, I've been retired for going on 8 years now. Can you believe that? And you, are in the company and still in the company, and so we worked very closely together. So my question to you is, we've talked about doing something like this, an MSO, a management services organization type of thing, for literally decades. So, how did it get off the ground, and how did it get from just talking about it all the time to actually have some wheels on the bus and it's going down the road?
Yeah. So I think, I mean, you started this long ago and even predated you with things like Northwest Rehab Alliance. How do we get organizations to come together to share burden for a collective good? So it started back then, but we've talked for years about how can we do the mythical MSO where we can do these things that larger organizations have scale to do well. How can we provide that service to other folks who maybe otherwise couldn't do it? But it always was this ethereal, well, let's just kind of do this thing. Well, about 2.5 years ago, we got some clarity. Healthcare hospitals are starting to do more of this with Community Connect on the Epic side of things. So I think they're starting to develop models of how you do this to say, well, why don't you leverage the size of some organizations, but spin an organization off the side focused on health IT, because that's an anchor that a lot of people struggle with, and then surround it with some of the other peripherals, things like business intelligence, things like revenue cycle management. And you can add layers to that onion, but using an anchor of a system that everybody has to have, and this system that you can get lots of people to come onto and scale it faster than one org could do. So I think it helped us to get focus on one area of what could be a managed service. And then we started talking to a lot of organizations. There was a lot of folks who struggle now. They've been with their EMR for a long time. They're looking for something different. They have a ton of data, but they don't know what to do with it. It's not serving their decisions. They're hearing about AI and all these vendors are coming to them. Hey, buy my wares and your life will be awesome. And they're like, well, that's what we do. So people are starting to ask for it. So naturally it evolved out of a need.
So I have a lot of questions here, but the first one is just for our listeners who may not understand the difference. Describe the difference between an EMR and an EHR.
Yeah, so big distinction now. So electronic medical records have been around a long time, and the simplest term would be we used to do it in paper charts, and if you put that into a word processor, basically, so you type it rather than write it, that's an electronic medical record. An electronic health record is connecting all the medical records from the different organizations into one meta health record. So we now can monitor your overall health across different disciplines or different departments in a hospital. You have a unified record. That's a health record. So some medical records do what we call interoperability, where they connect a little bit to some other and share some information. But a unified health record, there's a national standard for this now that we're starting to conform to. Medicine beat us to the punch a while ago. But you can use interoperability. So naturally, when a patient comes in, you not only see your record, but you can see everybody else. That's what a certified health record does. And we still
And and I think that we can safely say that, especially in private practice physical therapy, that most people use an EMR. And the reason for that they will tell you is that it's just too costly to use an EHR. And we know that medicine, physicians and hospitals and whatever got some government help back in the, I don't know how long ago it was, to invest and do this. So my question is, I think what you're saying then is with this new program, Hychara Health, is that you can actually say, well, we can give you access to an EHR without having to buy the whole bus.
Kind of. You get EHR, you get the whole bus. So I think it's two things. One, because more and more even of healthcare is getting onto these certified EHRs, naturally, like all things, when they're new, they're really expensive. And then when more people use them, the cost comes down. So the cost is coming down for all EHRs, especially as technology improves. But the other thing has to do with scale. If you have five providers, you're going to have a real hard time penciling out a full EHR. If your five providers add to 5,000 other providers who are now through an MSO using the same system, well, now we got to drop the cost way down because you leveraged your little size with everyone else's size. You became a bigger entity. So yes, you give access to it, but you get a full-fledged, all the bells and whistles that you would get with an EHR.
Okay, and so how is this different then? Some physical therapists in private practice might hear this and say, oh, what you're talking about is a network. How is it different from a network?
I think in some respects it's similar. So, I mean, a network is just, if we say like an IPA where you have independent entities, Northwest Rehab Alliance in the Northwest is one. So you have independent entities that come together for some shared purpose, contracting, quality, these sorts of things. That's at its core what an MSO is going to do. But now you're going to expand that to we're coming around a common technology. We're coming around common definitions of patient experience, common definitions of outcome measures and business intelligence measures. And so you're just expanding that, coming together for a few things, coming together a few more. But you still can maintain your independence. It's just now you're unified under one entity. As we go forward, though, one thing you get when you're now on a unified platform is you potentially could take individual entities through the MSO and now bill as one unified tax ID number to a payer. So now you actually to the payer are unified because you have anchoring technology. So now networks can never do that because you're all separate. When you unify around a technology that now the payer interfaces with, now it gives you leverage with payment as well.
So if I sign up for this service and become part of this program, I'm going to change my tax ID number to be common with everybody in Hychara Health.
When you keep your tax ID number, but as you bill out under a unified MSO tax ID. So you're still an
Okay.
individual entity. You have your own tax ID number, but for billing purposes, you bill through the MSO, and your unifying technology allows you to do that.
Okay, and in some of the things I've read about this, you state that our mission is simple to help PT practices thrive by optimizing operations and improving patient outcomes and empowering practitioners to focus on what they do best, which is treating patients. To be honest, we've heard this before, right? We're going to do something that we're going to save you a bunch of time, documentation systems or, other things that do front office functions for you. Why is this different? And why, if I'm listening to this, would I not say, I've heard this before? It usually doesn't work.
Yeah, and I'll be the first to say this is what I've had all these vendors pitch to me over the years, and I think the fallacy in any one single technology that says we're going to fix fill in the blank is technology is rarely the sole problem, and a single technology is almost never the sole problem. Usually, what it is it's technology is part of the problem, process is part of the problem, people and accountability is part of the problem, having numbers that you can be accountable to is part of the problem, right? And this oversight and strategy and vision is part of the problem. So it's multifaceted. And so I think our approach that is different and what we have found has worked for therapeutic associates and out of that born this now extended model is to say, let's take individual technologies that are each top of their game for what they do, but connect them, wrap those in some processes that are designed not by a technology company, but by a provider organization that's had to use them for years, and then wrap that all in business intelligence that says these are the right numbers that we say move your goals, get them to the right person at the right time in the right format so we can see how we're doing, and when we adjust, see the effect. So it really is more than technology. It's technologies linked together with processes, linked together with strategy, linked together with business intelligence that tells you how you're doing. It's that whole process versus a single entity.
And as we know, costs of service has just become such an issue in our profession. And so hearing that, it sounds good, but it sounds expensive. So, are you suggesting then that by putting it all together and you be the person who deals with all the different vendors who may be part of the system, that you can provide a better cost structure than if you went out and just bought these individual pieces?
Yeah, yeah. In a nutshell, yes. You're always going to get scale when you can use other people to scale you rather than having to scale yourself. So yes, we can get the cost down to competitive with less features because we have more people on the system together. But the other thing to be clear is the problems of one organization, while similar to everybody else's, they're not exactly the same. So our solution can't be one size fits all. So for some organizations, they might say, look, I love my revenue cycle process. In fact, I actually love my EMR. It's working well. My people like it. I'm just not understanding the data side and how do I get the data out of that and how do I make decisions? Well, then we can come in and say, well, cool. Let's wrap this in some business intelligence with some consulting. We'll leave the technology out of it for now. Let's set a path forward on this piece that we found that needs addressing, and let's go forward on that. Narrow technology, or maybe even no technology. Maybe it's consulting to start with. So we can flex up or down our approach based on what you need. But yes, if you do it all, it's going to be more expensive. What we also do if you want to add more services is to say, well, what's the ROI on that? So if you add this, we've seen this change in your net revenue. So for the cost, if you're going to pencil out if we achieve this, and here's the probability that we think we can hit that.
And part of this too, what you just said, the consulting part. I'm biased as you know, because I think Therapeutic Associates is awesome. I spent my whole career there, but it is arguably one of the most successful private practices, in the country, and still is. And so now what you're also bringing to these services, from different vendors or whoever it may be, but you're also bringing in this piece that's going to say, we're going to help you understand this better. We're going to help you run your practice more efficiently from our 70 years of experience in this field. We're going to help you do that along with these services. Is that correct?
Yeah, 100%. And I think my and to that is I've been with Therapeutic Associates a long time. I've worked for some other organizations before and interim. Um, but I think if we would have offered this 15 years ago and just say, well, let's just replicate the TAI way in other organizations, that's not going to work necessarily. TAI, with all the changes post COVID and even pre, has had to say, okay, take a step back. We're a big organization that had a lot of successes. How can we optimize these little pieces and find areas that now need to be addressed rapidly? And so that ability to keep looking around of where we need to go, we refine and say, that's what we need to do. So while yes, you get the history of over 70 years of learning of history of a way to run private practice efficiently using IT and business intelligence, we also have a way of finding efficiencies that TAI has had to even morph even over the last few years.
It kind of reminds me. I remember I met a guy once who had a business, and the business was like these huge healthcare organizations. Let's say they're going to change their EHR from this system to another system. You can imagine how daunting that is. But he had a business that basically would say, "No, we're going to do it for you. We're going to come in and we're going to train your people. We're going to understand the product. We're going to do all these things. So you just go do your day to day, and we're going to handle that for you," which I thought was brilliant. Uh, is it something like that? I mean, you're getting some of these other vendors and some of these other companies to come into your MSO, but you're going to be the one that trains people how to use it, not the company that maybe is a bunch of tech guys who don't understand physical therapy.
Yeah, mostly. So my research, my PhD research was really on this concept of socio-technology. So if we use EHR implementation as an example, when we go to implement, some of it is the technology change, but a lot of it is the sociology of teams and the workflows of the technology. So the art of EHR implementation has to do with understanding the sociology and the technology. So I bring that up because yes, that's part of what we can offer. Even as a consultancy, if you didn't go with our main product or our minimal viable product piece with our EHR and all of that, if you just wanted consultancy on implementing an EMR, we can do that. But it's not just us coming in and doing it, it's us understanding the workflows, helping you create. You're going to have a leadership team in your organization because even though you don't want a tech guy training you, you also don't want an external person even I'm a PT and have informatics training, but I don't understand the nuances of your practice. So you're going to need a core team that we can help train the trainer kind of idea. And then we create the strategy, the measurement and all of that and the approach, but help your team with us do the implementation. It's not just push you out of the way and we do it. We could do some of that, but it's empowering you to do it well. And then more importantly, then we could step out and you can keep operating it and succeeding.
So those of us that have been around for a long time, I can remember from day one, the first computerized documentation system was going to save you time and give you more time to treat patients. And we can probably say, I don't think that ever happened. But are we at a stage now where AI can actually do that? Do you think that we're there, that now we can actually say, you know what, AI is going to make a difference and you are going to spend less time doing chart notes?
Yes, with a caveat. And I think I've made this bold prediction, I'd say in 5 years, and I bet it's more, probably like 2 years, that the documentation burden in many organizations will be nil if you can do this appropriately. My and to this is AI itself is stupid. It's just math that someone has programmed. And so if you were just take Chat GPT, for instance, and talk to Chat GPT, one, it's not HIPAA compliant, so that's not going to work. But two, it's not going to have the syntax, or what we call semantics. It doesn't understand the nuances of the things that we say. But there are tools out there now, and we're working with one of these as part of our program, where it's been trained on hundreds of thousands, probably even millions of notes for physical therapists that now understands the semantics. Now the model knows when I say something what I mean, and it can attach it to something where we have what's called thought for thought translation versus like Dragon of old, where it's just word for word, you dictate. That's AI, but that's stupid AI. It's just natural language processing. This semantically correct AI is going to take what you say, take out the fluff that's not germane to what we're talking about, and give you the most important thought that's useful for an EMR. That's here now. We're starting to implement that.
So can you say what group you're working with that you're going to implement that piece?
Yeah, and I've presented with them the last couple of years. So Prediction Health has been a group that I've connected with 3 years ago. Before, since they were barely getting into this space, but they got in on the compliance side of things, and then we're taking notes and doing retrospective analysis of the data to give you reports. But all the while, they were taking in all that information to train their models to make this ambient scribing tool better. So they're not the only one out there, and I think the market is speeding up into this position. But I think they have the lead in understanding what PTs want. They've been able to pivot. For instance, last year at PPS, they had a model they showed me, and within a couple of months, with some feedback, they were able to morph and blow my mind with how quickly they were able to improve the semantics and the applicability of it. So I'm not here, I don't have any dog in the fight, other than I think they're a great group to work with. They've been really smart and really thoughtful. But more important to me, they listen and they find applications that take burden off the customer. And our PTs now that are implementing this, you just see all kinds of reductions in the burden of documentation.
So just, I think you've already said this, but I want to emphasize it. So let's say that that's my biggest uh, uh, problem I think I have in my practice. So I could go to Prediction Health and buy their product and go, or I could go through, your organization, Hychara Health. So why would you say it'd be better to go through your organization than for me just to go to Prediction Health?
For some it would, and for some it wouldn't. So I'll be the first to tell you that. But so outside of my work with Therapeutic Associates and Hychara, I do research in medical scribing. So I'm part of a research team for Oregon Health Science University, where we look around the country at how do you use medical scribes, back predating ambient scribing, but now we're doing research on ambient scribing as well. And one thing we have to recognize is, while technology is cool, it's still socio-technology when it's implemented. And so if I'm a provider that doesn't think out loud well, and I can't get my thoughts out, or I mumble a lot when I talk, or I just hate having a computer in the room, you better darn well not invest in this technology, because it's not going to work, because you have no input. So while the technology is the technology, just like implementation of an EMR, oftentimes, and we've even found this in Therapeutic Associates, to implement it's not as easy as just turning it on for everyone and say, high five, this will be awesome. But we have to find out who's using it, of the people that have trouble using it, what do we have to do to make them better users of it? And then how do we ensure that we're getting out of it what we want? It's not just as simple as paying for it and turning it on. Again, back to the point of it's a social problem more than it is a technology problem. And that's the part that we handle, is helping that social wrapper.
So you might have to add a clinical psychologist to your team to change mindsets, right?
Well, yeah, I think that I went into informatics wanting to develop clinical decision support rules and all this. I actually came out a social psychologist. My PhD was more in organizational psychology than it was anything else, for this very reason, because I was moved. When I did my research, I started to say, if I just make the right data and get you the right information, it's solved. And I had great researchers that were part of my advisory team, and they helped me recognize it's about people. And no matter how great the technology is going to be, you still have to have a person and their workflow and their team. So that's where my passion is. And while I'm not a formal psychologist, man, I have passion for this area because it's the same.
Yeah. It reminds me, and tell me if this is a true recollection I have, but didn't we do a study where you actually had scribes work with physical therapists side by side, and you actually kind of showed or proved, or however you want to say it, that it did save them time and it was a different way to do things and save the PT time, and there were still PTs that said, "Yeah, but I don't like it."
Yep. Yeah, I paid for so this was 7, 8 years ago as I was doing my scribe study predating ambient scribing. I paid for and trained a scribe. I used them and I fell in love with the process. And I was like, why aren't all PTs using scribes? So I said, I'll pay for this person. I'll put it in 3 different clinics. And I purposely picked a clinic that I thought was going to be kind of really flexible and they were going to uptake it no matter what. One that was a little bit of standoffish and others I thought wouldn't. And that panned out. Same training, same ability to help. And when you put it in different situations, it behaves differently. That is the essence of social psychology.
So, is your strategy to deal with that part first? I mean, do you have to change the mindset and the way people think about things before you implement a new process?
Yeah, if I come in to say I have to change you, then I'm probably starting off wrong. If I
Yeah, yeah, that's good. That's a good point. Yeah.
to understand you, yeah. So I'll give an example of one physician we worked with in our research. He was a super epic user, and we were surprised this guy never used a medical scribe. We said we gotta study this guy. So we followed him around for a day. But he was so great at his smart phrases, and he had optimized his system so much. He's like, I don't need a scribe. Like documentation is not a burden for me. And I suspect this sounds weird, but I suspect there are some folks out there who they say documentation isn't a burden. Now I'd ask, now how compliant are you with your documentation? How much are you copying forward? There's probably some other issues we might want to deal with. So yeah, though I would want to start to understand, and I think we're going to have a segment where you say these people are going to get instant impact. Cool, low drag, do it. Train them, measure it, go. There's going to be another group who probably want to do it, but are going to need some help because maybe they're technophobic. Maybe they just have trouble with this processing, and we're going to have to help counsel them. And then there's going to be some folks that are standoffish. So we'd say, I don't need to change your mind. How else can I help? Maybe it's in optimizing your system. Maybe you want a real person and you just don't like technology. Or maybe we say, cool, you don't need to be part of the game. And that's fine. That's your choice as well.
And do you think sometimes in the smaller practices, when you think of going to this level, is it reasonable to think that I might say, gosh, I might be a little out of compliance and I'm probably not doing this exactly the way I should. And if I go in a process like this, then they're going to make me do all these things, which are going to take way more time. Is that kind of a common fear?
With the ambient scribing, probably less so, but yes, that what Prediction Health, for instance, started with as a compliance score, an audit risk score. So yes, you're going to say, I copy forward every note, I change 2 or 3 words, and I'm in and out. And they're probably going to say, ooh, man, a payers, they have AI too. A payer is going to see this. You're at very high risk of having audit flags. So yes, you need to change. And so the intermediate would be, yeah, anytime you change, it's going to take you a little longer because there's a learning curve. So we have to help folks to say, you found a path of least resistance, but maybe it's not the best path. Can we help you chart a course of change to get over that lack of efficiency as fast as humanly possible? And then you're going to find efficiency gains on the other side of it. So yes, you're going to have that. We don't want to hang out in this area that you have a lot more work because no one wants to stay there.
I work with a lot of clients that, when trying to scale their companies. And a lot of times it comes down to when should I hire a COO, or when should I hire a CFO, and when should I do this? And the position that you're in, this informatics position, and like you said earlier, understanding data. We have so much data, but we don't know what to do with it, right? So it would seem, I bet, that a lot of people are thinking, well, that's just, only huge companies are going to be able to afford somebody like that. So when does a PT company, how important is it, and when should they add somebody that can help them just understand the data that they have?
I'm jaded because you're talking to informaticists. So I would say if you're a practice of one, you should be using some data to drive your decision. How do you make a decision without data? Now, this doesn't have to be complicated. You might get an Excel export of your visits and your units or your RVUs, and you set yourself a goal and you track how you're doing. That's great. And it's uncomplicated. Now, when you get in my research, I found that when you get over 4 practices, the ability of one person to kind of oversee all of that without some help is really hard. So I think that inflection point past 4 practices. Now, whether that's an informaticist, probably not, but maybe at that point you bring an external vendor. This is why we're here, is to say, well, what are your goals? Like, what are you trying to achieve? And then, okay, what data elements can we get? And then let's create a story that'll help tell us whether we're on the right track for that. I think you should bring that in really quickly, but the low drag is do consulting and pull it in as an Excel spreadsheet, and that's pretty simple. To bring in an informaticist or to bring in someone who's going to harness the power of a data lake or Microsoft Fabric or all of these sorts of things, you don't need that, but it's really nice if you just have it delivered to you and then it's aligned to your goals. But get a little bigger for that if you want to do it yourself, or when you're small, just say, "Could you do it for me?" And that's why we're here.
So in essence, that's kind of what you're providing. You're providing a smaller practice who probably can't afford to hire an informatics guy, but you can do that for them by being part of this MSO or organization.
Yeah, in the data, yes, that's actually the easy part. It sounds weird because most people don't live in data, but actually the wrangling of the data is the easy part. For me, and I think the value we offer is strategic discussions. What's your goal? What are you looking for? What's your history? What are you concerned about? What are the variables that are fighting against you or for you? Once we have those, then we can design a data story that matches what you need. So it's not just, hey, we're going to give you this off the shelf dashboard. We totally could do that, and that'll help maybe 70% of the problem, but we can nuance that based on where you're going. And sometimes just the exercise of asking that question, having an outsider come in and say, man, what is our goal? What is our strategy? What is our competitive landscape? Makes for a better outcome.
When you look at the world specific to private practice physical therapy, I think what we know is that there's a lot of single practitioners that have, single clinic. There's a lot that have 2 or 3 or maybe 5 or 6. There's fewer that have 10. There's much fewer that have 30. And over 30, it's a pretty small group. So I'm curious, as a business model, are you focusing more on the groups over 30, and is that your target point? Or do you feel like these smaller practices can also benefit from your services?
And this has been the evolution of a startup company, is you have to get your market segmentation down, right? So initially, from dollars and cents, it would make the most sense to target mid-sized companies, so that 10 to 50 range, because if you get a few of those, you scale really fast. The reality is what those companies need versus what the companies that are in the 5 to 10 need versus what those under 5 need. It's totally different. And so that's why our sales approach is different. We're certainly targeting, if you want the full meal deal and us just to offload everything, those mid sizes, you're already spending probably much more than that now. So it's an easy conversation. When we get down to the 5 to 15 range, now it's probably going to cost you a little bit more to do the whole thing. So does it make sense? And how do we do that math to see if it pencils out? Smaller than that, you probably don't want the whole meal deal. So can we slim it down enough and give you what you need, or can we a la carte it, or do you want more advisory services for us to come in and use what you got but help you guide it? So it's segmented kind of in those 3 populations, and it's a little bit different for each.
And when we look at AI, I think most of us can understand how AI could help us with the documentation piece. But tell us what are you excited about with AI doing, beyond the documentation piece and managing and making our practices more efficient?
Yeah, I think there's tons of business and clinical applications to where AI can help us. So some interesting questions that we're poking around on would be, I get a patient that comes in, and by visit 3, I want to identify my patients that are at most at risk of not completing their episode of care or not achieving some functional outcome. You're going to need to know this as we get in more to the risk-based world and this value-based contracting. You can't just hold on to patients forever. You got to have happy patients and achieve their goals. And so if we can use AI, if we have enough background data to build the models, to predict based on a few factors when a person comes in, how they're going to progress through their course of care. Maybe there are other things right now. There's all kinds of payer constriction happening. We know that there's a rise in the federal payers or in the state funded plans, and those just don't pay well. And we have to be much more concerned with what our panels look like, our payer panels of our patients that we're seeing. And we can't just first patient calls, give them the first slot that we got to do 10 years ago. But we also can't say, well, no, you have Medicaid, I'm not going to take you. That's ethically not okay and actually contractually not okay. So AI can help us understand, okay, where can I offer these spots to take care of my patients, but also not bankrupt me or get my panel so off kilter that I'm doing a ton of work but not getting paid for it. This is what AI was made for, because it allows you to pick variables out emergent through your practice and make the models smarter and smarter. And then the AI gives you recommendations on what to do based on the model optimization.
When it comes to outcomes, you and I lived that world where we were fully into it and trying to make a difference in the profession. And is it safe to say we that kind of failed? And do you think that if AI was at the level it is now, that it would have helped that system? And I'm not being specific just to Care Connections, but all the other outcome systems that were out there, they just seem to really struggle to get traction.
Yeah, my answer would be on 2 fronts. Well, one, it failed because the payer didn't see it as valuable, or not to pay for something they don't see as valuable. So why would I do it if the payer's not going to pay for it? But payers are starting to use machine learning and AI now anyway. So where they couldn't see patients who were not making functional gains before because their systems just weren't um, uh, robust enough to do that. Now they are. The Evacores of the world, the Optums, you're sending this data in, and while they're not using it now, and we all get frustrated with that, I guarantee they're mining it, and I guarantee they're taking it in to build their models to come in and say, you're not giving quality care, and my AI model is telling me that. So first and foremost, we're going to have to, because they finally can deal with it. But then to your main point, yeah, it was too obtuse for us. Well, what do I do with it? How do I know how a patient's doing compared to how they should be doing? How do I know in aggregate how I'm doing versus just focusing on one patient? This 100% is what machine learning and ultimately clinical decision support and AI augmented support can help, is because now we can give the providers, hey, they filled this out and this is what you can expect, or and this is what you should do. We have that here now versus before. We just collected the outcome and said, okay, cool, you went from an oswestry 70 to a 40. I don't really know what that means. And now the machine learning and decision models can help you say what to do with that.
So if we're not using Care Connections anymore or any other outcome system, what is Hychara Health doing in that realm? What are you providing so that we can learn and become better clinicians based on what we do with patients and whether they get better or not?
Yeah, so again, this is where I think where Care Connections struggled was we tried to be the technology vendor and the applicator and the provider. Why don't we just partner with people who are good vendors of technology? And so that's what we do. So at least in our minimal viable product that we sell of the core technology, we bolt on the front. Second door health is what we use, but there are other applications for patient engagement that live here, or digital front door, that allow you to administer based on rules certain patient reported outcome measures, other questionnaires. They can serve those into your medical record that can then drive decisions, and then your medical record can then serve that up on reporting to tell you how you're doing. So again, it's back to where I started, this integration of these multiple systems into a workflow. So now you have the data coming in, it's presented to the provider in the EMR, they don't have to go somewhere else to find it. And then the leaders get to see how you're doing in aggregate. And then the last piece would, if you want to do MIPS reporting, and we could do a whole podcast on MIPS reporting, but if you want to do that, we could bolt on, there are a few registry vendors out there that you can report through, but I would really question, what are your motives in doing that now?
Well, you're the designer and the guru of this system, and I'm definitely not as up on it as you are by any means. So, tell me about this approach that I haven't asked you about that you think is important to discuss.
About the MIPS or the
No, about Hychara Health and that system, the MSO approach.
Oh, the MS report. Yeah, I think that the biggest thing to understand is that why are we doing this? What absolutely breaks my heart and all the leaders that are working to design this is we have private practice PT practices that are having to make a decision to either sell out. I can't do this anymore. I'm frustrated. I'm tired. My only option is to sell to private equity, and that's not a problem, but they feel trapped. I have to do this because I have no other options. I would rather you make the decision, say, I do it because it makes sense to me. Or I just have to leave it because it's not doing what I want, and out I go. You're just in this lonely place of not being able to make wise decisions because you feel trapped. What we want to offer is that there are strategy solutions, there are technology solutions, and then there's the ability to link to other organizations that are doing similar sorts of things. So you can off burden yourself from those other things. I think the last and the most important thing that I would push out is if you go to PPS the last couple of years, go to CSM the last couple of years, what is everybody talking about? We have a workforce shortage. We have unhappy people. They expect more in wages, and my bottom lines are shrinking. How do I deal with that? Well, if you can have some technology and processes that help decrease the burden on your folks and help them to see, you want to free them up to do what they're good at, which is take care of patients. You have ways to measure on them to show them that you value how they're doing with patients through outcomes and net promoter scores. We can put processes in place to do that. That you ultimately measure these things, and all the things you're asking them to do, you come back and talk to them about it, and they can see that it's important. And at the end of the day, on the reimbursement side, we can gain you operational efficiencies that can, in the end, drop your expenses, which will raise your revenues. So are we working on the income side and the provider availability side? We can do that with technology, or can we do some things to drop down your costs? We're trying to pull both those levers to help you stay viable. All the while, again, while getting to focus on what you love, which is running your practice, serving your community, and loving on your patients, and we can deburden you from those things that maybe you don't love doing.
So, have you noticed a different in attitude? You know me well. You know I'm a huge collaborator, believe in collaborating with all kinds of people. But in the early days of the network, remember it was like pulling teeth to get people to come aboard because they were afraid that you were going to know something about them or steal one of their secrets or find out too much information. Have you noticed a difference in attitude with your private practitioners today of looking at these type of collaborations as being more positive than in the past?
Yeah, I think for two levels. One, urgency breeds desperation or change in the way you're doing this. So when people are
Mhm.
grasping at straws for something, you're always willing to look at a different approach you weren't looking at before. So we certainly see that. But I think it over the last 10 years, just a model of collaboration, a professional humility. It probably it has some connections to the DEI stuff of over the last 15 years, where people are just saying, hey, maybe my perspective is myopic, and if I have someone else's perspective with mine, together we can make something better. This is kind of a national movement that we've pushed over the last 10 years or so. This is it's promulgating into what we're seeing when we talk with folks. So I think people are more comfortable collaborating because they're recognizing that they don't have all the answers. There's some professional humility, and then this assumption of positive regard that if someone's coming alongside of me, they're not doing out of malfeasance, they're trying to steal something from me or get up on me, but maybe we just want to help, and maybe we like each other and want to work together. I do see more of that collegiality than maybe we had 10, 15 years ago when we had similar sorts of conversations.
So, Chris, I'm a big fan of yours and you, I've always felt as a physical therapist, you were so far ahead of the rest of us, as far as what you're thinking down the road. So I want to know what is in Chris Hoekstra's mind right now that you're really excited about in the future? And maybe on the flip side of that, what are you worried about?
Yeah, I think in the future it has to do with using strategically aligned machine learning to make better decision makings. I think we are primed for it right now. That if we can be clear on what questions we have or what objectives we want to solve for, either there's a vendor that can do it for you pretty darn out of the box, or we can get data scientists to come alongside you and pretty quickly we can design models to answer those questions. The data is becoming cheaper to process. Storage is ridiculously cheap now. So answering these questions is easier. On the flip side, my concern is people are just going to jump at, oh, AI is going to make my life better. So sign me up for ambient scribing, sign me up for this machine learning company because they're going to make my life better. Without strategy and without guidance, you're going to waste a lot of money. And so I think that would actually be tied to my biggest concern. I have to be honest that in the chase of trying to make our panels better and to stay viable, while we're getting payer constriction, we're going to waste our time focusing on stuff that's not important while the payment structure continues to constrict, 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 constrict. And then we're down to, I'm not going to say a single payer system, but you're going to have a monopolized payer system. And now you are a servant to the monopoly because we've wasted our time doing all these other things. And so that's my biggest fear is we're all going to chase lots of amazing things with technology, but if we can't come around a common, these are some things that have to be solved for in the next 5 years, we're going to miss the boat, and there's going to be this payment compression thing is going to hit us, and we didn't fight because we were distracted.
So on the private practice business owners side of the fence, there's some exciting things about AI and we can be optimistic and hopeful that that's going to help us. Do you have concerns that on the other side of the fence, are the third party payers, they have robust AI systems too. Are they going to crush us with this?
Yeah, that's what's happened. That's why I say I use Optum as a great example because they're in the news right now, and we're in the midst of submitting all these outcomes that aren't getting used, but are getting used. But why are they doing this? Because they're trying to make their AI models better. You have to recognize this is what they're doing. And so that's going to come to fruition where now payment policy is going to be dictated on their AI models making decisions. And if we don't have refined answers to that from our side, where we own the clinical data, they don't have that. We're readily giving them the outcomes data, but we need to harness what we have to battle against a narrative that they're going to have. It doesn't need to be negative. They should try to make healthcare cheaper. That's their job. And we should try to make healthcare better. That's our job. We have to find a way to link, and data is going to be that language that we can deal with
Yeah. So you're hopeful we can get there?
it. Yeah. How do you measure hopefulness? Hope and a dream doesn't make strategy. So yes, we've got the smarts to do it. We've got the data to do it. Do we have the focus and the fortitude to do it? Jury's still out. I'm hopeful, and that's why we're doing what we're doing, is try to help people come together around a common thing that gives you fortitude in numbers and then gives you focus. But yeah, the science and at least the will, we have lots of great people. I hope that we can leverage those.
And so to just kind of summarize this whole discussion in a way, you and I come from an organization, a bigger organization that's had resources and had some good ideas and we're able to do that and so on. And I think what you're saying is we're going to use that experience and help smaller private practices that don't have resources like that or don't have that exposure to kind of things that, something like a Hychara Health can help them get that was out of their reach in the past and maybe help them stay in private practice longer.
Yeah, that's the goal. My research that when I did this, I took companies around the country from 1,000 clinics down to 4 clinics, and I had some compelling questions around how do people use technology or not use it? Why do they use technology and not? And then there was a quality bend to that. And my take-home message to what you have said is the core problems are the same. Actually, at the 4 clinic and the 1,000 clinic, prioritized, and we don't use our data consistently. So yeah, the common problem. So can we find a solution that is flexible enough that can be applied to big clinic groups and to small clinic groups? And then can we scale it enough so that it makes the right price point for those smaller clinics, and you don't price folks out of it? And that's our approach. So yeah, I'm hopeful we can do that. I know we can help, and I think we can be part of the solution. I'll say we're not the answer. It's got to be people coming together, but my hope is that we add to the answer.
And then in the bigger picture, when you look at healthcare outside of physical therapy in the hospital world and the physician world and whatever, are they making good progress in that area too? Do you think they're headed in the right direction, or are they kind of got their head in the sand as well?
So from hospital PT or hospitals?
I mean, just the hospital system. You look at, what hospital, all we hear about is hospitals are in trouble financially, and physicians are frustrated, probably even more so than PTs. So are they making progress to solve some of those issues as well?
Yeah, from the technologies side, they have us beat. So I teach at OHSU now, and I have optics into what they're doing on their finance side of things, and what they're doing on their clinical side. And I think from leveraging their data, from using technology to drive business and clinical decisions, they're all in the right place. I just saw yesterday, Brigham Women's is coming together with a bunch of hospitals to come together to create a consortium around what's meaningful use of AI to drive healthcare. I think these consortiums coming together rather than one system trying to do it all, this is going to be the answer. So I think they're doing great things. The risks that they have is they're so big, and that it's this bureaucratic nightmare for them to try to move their ship quickly. That's where I think we have the edge finally as private practice, because we can be nimble, but now you can also be distracted by being nimble. But if you can be nimble with purpose, we can pivot much faster than a hospital system. But I think we're all going in the right direction. It's just, can we get there with all the forces that are on us? I'm hopeful.
Yeah, that's great. Well, Chris, I could talk to you for hours. You're always one of my favorite people to just sit down and talk about ideas because you have such good ones and you really put them together well. But what haven't I asked you in this session today that you think we should make sure to get in the show?
Well, I think I kind of alluded to it. Is what are we doing, and is it enough in PT to help our future generation of PTs, one, enter the field, but two, thrive in the field? I think I'm not going to answer just that, but if we have any conversation about technology and it doesn't have a strong anchor to the current state of our PT workforce and the future state, well, then we're not talking about the right thing. So again, I think the biggest thing right now, and if any folks have seen, I presented with Prediction Health on kind of the value of ambient scribing and use of big data at the last couple PPSs. And my message is always, yeah, and at the end of the day, you're doing that so that you can deburden your providers, and your providers see that you have a shared purpose. And I think this is the tough part when we have financial constraints on us, is that it's easy for us to focus on operational metrics. It's easy for us to focus on financial metrics that are going to keep us viable, and we should. But when your providers think that's all you focus on, or you can't see that we're helping to make your life better, and when you have a better life and help more patients, the effect is to drive up revenue, we have a disconnect. So I would just ask anybody that's considering taking on services like ours or just wants to get into technology is to ask yourself, and how does this affect my people, one? And then two, and how can I make my people the focus of the thing that I'm doing, and the revenue and the profit and all of that, the outcome? It's a real kind of hard judo match for you to get into, but if you can do it well, I think that's how we engage the people, and the people are the lifeblood of our companies.
Yeah, absolutely. 100% true. I totally agree with that. You've been a guest on the show before, so you know that at this point in the interview, I always ask my guests the same common question. So that question is, in relation to leadership, what is a pearl of wisdom that you could leave us with today?
Uh, I would say I'm a big fan of Adam Grant and his kind of think again model. So I think in any leader, I challenge myself to question myself, and hold all of my inferences loosely, hold all of my uh, insights loosely and prove myself wrong. Treat life like a science experiment and try something. No, it's not going to be perfect. Find the errors in it and make it better. If we can do that, you're never going to be wrong. My fear is, and what I tend to do, the more school I take, just you naturally do this, is you trust your knowledge more. And that's a real dangerous place to be. So never trust your knowledge. Use it to test a hypothesis to get the next level of smarter.
Well said. Well said. Well, Chris, this has been a pleasure as always. It's great to connect with you again. You're living in Nashville now, even though you're working for a company in the Pacific Northwest. So that's a new twist on our work environments today. But you're doing great things for that company, and it's just really great to hear and see all the things you're doing. And I applaud you for taking us all down the road where we need to go. So thanks for doing all you do, and I really appreciate you being on the show today.
Yeah, thank you for the time, Steve.
Take care. See you later. Bye-bye. Thank you for listening to another episode of Profiles in Leadership. To listen to all my interviews, subscribe to Profiles in Leadership with Steve Anderson on Apple Podcasts, iTunes, and many other popular podcast platforms. Some of these interviews are on video, and you can search YouTube for Profiles in Leadership with Steve Anderson. You can also access the entire library of interviews on my website, orange.coaching.com, and that is orangetheword.coaching.com, and go to the Media Center and click on Podcasts or Video Gallery. You can also enter the website from pilpodcast.com.